I'm so blessed and so excited to be here with you all this evening. We had over 150 registrants for this webinar and currently about 57 people on. So, and I'm sure more will be joining us. Before we jump into the topic for the evening, I wanted to just take a moment to acknowledge that one of the greatest midwives among us has transitioned. I'm sure most of us are aware that we recently, that Mama Claudia Booker recently became an ancestor. And so I just want to take a moment of silence to honor her legacy and to recognize what a treasure and what an amazing leader, midwife, doula, legal advocate, friend, mentor, sister, mother, grandmother that she was to so many of us. And I feel her loss so tremendously during this COVID-19 crisis, because I know that she would be a beacon. And she is a beacon, because as an ancestor, I feel her spirit and know that she is leading us. And so I just wanted to take a moment to honor her. If you're in your home, feel free to light a candle, say a prayer, pour some water in the spirit of libation, and call her spirit with us into this space. Ashe. Amen. Thank you, Mama Claudia. So we are here this evening to talk about the COVID-19 pandemic and the crisis that it is presenting for our communities, and also the challenges that we are facing as Black midwives, Black birth workers, birth assistants, student midwives. I do want to say that this meeting is particularly for Black people who are working in birth work. So if you are not in that criteria, I would ask you to please excuse yourselves so that we can have, a safe space for us to share. We are often sharing with our larger midwifery community or birth worker community in spaces that don't always feel safe or that don't always feel inclusive. And so we designated this space to be just for us. So there's no way for us to monitor who's who, but we do ask that in the integrity of this webinar that you excuse yourself if you are not a Black birth worker. Thank you. So that being said, we know what we're facing. We've been inundated with information about the COVID-19 pandemic. We know that there are many coronaviruses that have plagued humanity for a long time, and that this particular virus is new to humans. It's known as SARS-CoV-2, and it is the virus that causes COVID-19, which is the disease. Part of the dangers of this virus is that it is spread easily from person to person. Many people who contract it will be asymptomatic or have very mild symptoms, and so then can easily still be moving around in the community and spreading it to others. Or there can be a period of incubation where it is being spread before people know that they have it. We also have issues of lack of testing. We have hospitals being overwhelmed, social distancing and stay-at-home orders and school closures being put into place. And we know that that is deeply impacting our communities, not just on a health level, but on a social and economic level, and causing crises for many families. So some of the things that we want to talk about is, what is the role of Black midwives in this crisis? We know that as Black midwives, we have always been on the front lines. We're often primary care providers for the families that we serve. And this is especially true in Black and under-resourced communities. And we want to know who's reaching our people, and also how are we protecting ourselves? For good reason, the attitudes in our communities have ranged from completely dismissive to intensely fearful. And all of those responses are valid given the history that we have had as a people. When we look back to even the last biggest pandemic in the United States, of the Spanish flu, what was the role of midwives then? We know that in the mid-19th century, midwives taught doctors a simple technique to prevent infection: wash your hands, to prevent what was known as childbed fever. Also, during the 1918 Spanish flu, the incidence of the flu, of contracting the flu, was lower if you were a Black person. But due to the discrimination that we faced as a people, due to the comorbidities, due to a higher likelihood of contracting other infections or developing into pneumonia, Black people's case mortality rate was higher than whites during the Spanish flu. And so we know there's a good reason for concern. And even more recently, when we look at the Ebola outbreak in West Africa, we have reason to be concerned about ourselves, because the mortality rate of the country's nurses and midwives was 10 times the rate in countries like Liberia, Sierra Leone, the rates, and Guinea, the rates of fatalities among healthcare workers were 10 times that of the normal population. So we have to think about not only how to protect our communities, but how to protect ourselves. So what are some of the responses you all are seeing in your communities? What education do we need to be accessing for ourselves and providing for our people? And we already know that we have higher rates of comorbidities. So how does that impact the care that we give as midwives? And when we think about particularly Black maternal mortality and Black infant mortality, how does that inform the care that we are giving, especially when, for many of us, our practice is based on low-risk patients? And so we're going to dive into some of these questions. We have some wonderful speakers with us who have volunteered their time to share their experiences, their knowledge, their research to enlighten us so that we can be a community that shares, that stays connected, that looks at best practices and protocols, and constantly tries to improve in the best interests of the public health of our people. So that being said, I'm going to get off the mic and allow each of our speakers to introduce themselves. Just share where you're at, your name, your pronouns, where you're at, and what you're working on, or any organizational affiliations you would like to share. Mama Sarahn, our elder on the call, would you please get us started?
Hello, everybody. I am Sarahn Henderson. Most people know me as Mama Sarahn, and I am living in Atlanta, Georgia. And I am a home birth midwife. Came into midwifery through the apprenticeship model back in 1980. So this month I am marking my 40th year being a community midwife. So this is my anniversary month, and I'm on my second generation of babies, which is really exciting. My service is Birth in the Tradition. I named it Birth in the Tradition because I wanted to learn and to reteach a lot of the mother wit that was lost over the last 200, 300, 400 years of caring for ourselves, and to ignite that and reteach how mothering, how midwifery was passed down and how it was practiced back in the days, and just bring life back to it. There's a lot that was lost during the years when midwives were being eradicated and when moms were being shifted to having their babies in the hospital. I am also a mentor for the National Alliance of Black Midwives here. And I had two students that would call on me periodically throughout the last 2 years to get advice and encouragement. So that's been very nice. And here in Atlanta, we have been, some of the Black midwives here in Atlanta have been getting together, number one, so that we can put together a bill, which we did. We have a bill that is on the table, but because session is being suspended now because some of our senators came down with corona, is kind of on hold right now, but we do have a midwifery bill so that we can become licensed. The granny midwives were the last set of midwives that were trained and certified through the state. And after the last grand midwife passed away, well, even before then, back in the 60s, they stopped certifying and midwives to become, to practice. And when I started midwifery here back in the 80s, I think we began in the 90s, several times trying to pass a bill, and each time it would be tabled to the next year and dismissed and whatnot. So we feel like we're closer to where, closer than we ever have been, and hoping that they will license us. Here in Georgia, the only midwives that are technically licensed to serve in-home births is if you're a certified nurse midwife. And so that's being challenged as well, because we've been, it's like they hijacked the name from us, but we're still going forward. And we've also created here in Georgia, we've also been meeting at the table and gave birth to the Community Midwives National Alliance, which we are developing that to be somewhat similar to NARM, where we can make midwifery education attainable, affordable, accessible for marginalized midwives, brown, Black student midwives, and just make it so that we can replenish ourselves. We need to replenish ourselves. And so that's that is who I am. As I said, I've been practicing for 40 years. And for 40 years, I have been pretty much running my midwifery service the same. It was redundant, but for new mothers, it's not redundant. And since Corona has made its presence, then it has caused me, as well as all of you all, to reevaluate what we're doing and how we are doing it. When I saw, I guess about a month ago, that this virus was in China, I started paying attention to it. Then when I saw it jump to Italy, I was like, okay, this thing is moving around. And knowing that pandemics can resurface, periodically, I wanted to keep an eye on it. So as I saw that it was spreading, then I started to really tune in and investigate through online, how should we reshape what it is that we're doing. And so some of the changes that I've seen, I'm going to take you through just a walkthrough of continuity of care. I'll abbreviate it because we only have like 7 or 8 minutes to talk, and then we have Q&A afterwards. So some of the things I saw that I needed to change was, one, I have 3 prenatal days. 2 of them are at my home office, and then another one is on at a separate location, is at an office. So I knew that I need to change that and have all of my mamas to come to the other location, not to my home location. So that was change number one. And then as I saw how it was really multiplying, it's almost like a Pac-Man, where it's just like, blah, 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 it just happens so fast. I was like, okay, let's really look at this. And so I have implemented changes, and I wrote a letter to all of my families to let them know what kind of changes they were to expect immediately. And so that was that we were no longer going to be meeting at my home office, that all of the prenatals would be at my other office, which is close to downtown Atlanta, and that when they come through the door, I will check their temperature, make sure that they don't have a fever, and then we would begin our clinicals. And so let me pause right there. So my prenatals are divided twofold. I call one part the check-in and the other part the checkup. So now all the check-ins are done virtually. I call up each of my moms the day before their prenatal day. So my prenatal days are on Tuesdays. So that's where I was today. So yesterday I called each of the mamas that were coming in today and triage them just to check in. How you doing? How you feeling? Have you been out? What about your husband or your partner? Has he been out or she been out? Are you taking extra care? Are you taking extra supplements? Even if you have vitamin C in your prenatal, it's time for us to do a booster and get extra vitamin C in there. If there's things that I need that we need to revisit from the previous prenatal, then that's our opportunity to talk about it. So then when they came to prenatals today, is very abbreviated. They come in and I run clinicals. So like I said, they come in and we take their temperature, they get on the scale. I like for mothers to feel like they are a part of their prenatal caring. I don't want moms to feel like I'm like the doctor and I do everything. So I teach them how to check their blood pressure. They get on the scale, they weigh themselves, and check the blood pressure. I'll think of the other one. And then all of the hands-on I do. And so their visits with me are only 15 minutes, 20 minutes max. And when that person, and so what they are also experiencing that's different is that now I am gloved up. That gives them a sense of me protecting them as well. So each person that comes in, I put on a new set of gloves. Each person that comes in, I have a massaging table that they get their hands on. And so each time one leaves, I lay down a new paper examination sheet, and that's changed. And I wear a mask as well. So today, I guess it was today, maybe it was tomorrow, I can't keep up, but now they're suspecting that this virus is also airborne. And so because I'm standing over a mother while I'm palpating her belly and listening to the baby's heart tones, I don't want my vapor or whatever you want to call it to get on her. And I say that because if you're in the cold, let's say that you're up there in New Jersey right now and you go outside and you go like this, you'll see vapor coming out your mouth. And so I keep my mouth covered with the mask. And that's something that they're going to see each time, and they appreciate this. They appreciate knowing that I am protecting them. I appreciate the fact that I'm also protecting myself and those who are in the room with me, my partner, my student and whatnot. And they appreciate the video visit the day before as well, even though it's different, they appreciate it. So like yesterday, I ran a class on the different stages of labor and birth. And then for another family, I talked about breastfeeding and breastfeeding paraphernalia. So each of my, conversations are tailored to those people and their needs, their particular needs. And so, like I said, they come in and they do part of their prenatal, and then they get on the exam table, and then I check them out, and then they're gone. and then the next person comes until it's their time to come again. Now, as we roll over, especially those mamas that are due now, I'm doing home visits, but my home visit is virtual. And so just the other day, through FaceTime, we did a walkthrough of the mother's home, her kitchen, where her laundry room is, her bathroom, and specifically her bedroom. And we talked about how she needs to have her room set up for the birth. If she's going to have a pool, which I'm considering too, where it would be, where's the hose going to be connected to. So anyways, that home visit, in other words, is a virtual one. And with the rest of them, it will be virtual as well. And then, and at that time, not only are we going over the logistics of their home birth, but we are also talking about changes with the home birth. So before I might come into a home where mom's there, both grandmothers are there, and the doula's there, and the partner's there, and then it's whoever's assisting me there. And so even that has dwindled down as well. I told them they can have their partner and me and the midwife, whoever's my partner. And that's where my comfort level is. And it's that way because I want to feel like I'm safe. I want to feel like I'm protected as well. And I'm putting my trust in knowing that they are self-isolating themselves. I'm putting my trust that the partner is isolating himself or herself as well. And I don't want to be concerned about other parties being there. And I don't know who they are. I don't know what their lifestyle is. I don't know if they're out in the world. I don't know if they've been out at a beach party. You saw how that was going on down in South Florida. And so I'm narrowing that down, and they're good with that. And then it rolls over to the birth. Well, I already, protect myself. I already glove up for births. I already wear an apron. However, I did go to a hospital supply store and got myself a gown, and the gown is like cloth on the outside, and then it's waterproof on the inside. And I have some goggles. I have my grandson's goggles that I plan to bring along with me, just in case any amniotic fluid decides it wants to splash itself. Then I have that to wear. I have two different types of glasses. One that my husband purchased on Amazon, and it looks more like ski kind of lenses, but it's sealed all the way around. Of course, he's protecting me also. And so he was able to find N45 mask. And so I have that to bring and that to wear when I'm at the birth. And when I am ready to depart their home, before I leave, I change my clothes. I bring an extra pair of clothes. I bring it anyways because you never know how long you're going to be at the birth. You might be there overnight. You might want to change your clothes and refreshen yourself if it rolls out to be a long labor. So anyways, I have extra clothes. I have a plastic bag. When I go to people's houses, I always wear house shoes. A lot of us like to take off our shoes, but I like to wear house shoes because some people's floors are not as clean as I like for them to be. And I like to be comfortable. I want to feel like I'm at home. And so after the birth, then I take everything off and I put on my new clothes. And then when I come home, I take everything that was in that plastic bag and dump it in the washing machine and put a little bit of Clorox in there. And then off it goes to the wash. Now I will come back and do the first home visit because I want to make sure that the mother and baby are doing fine. I want to make sure that breastfeeding is going well. I want to look at the baby. I want to check, make sure her bleeding is normal and whatnot. And then, so I do 3 postpartum visits. And if I need to do a 4th one, I will. But the remaining ones, they will be they will be virtual too. And like I said, all of them are good about it. So like many of us, we're getting a lot of phone calls from people who are planning to have their babies and who have been planning to have their babies in the hospital, who are scrambling, trying to find somebody that will take them on. And so I'm reluctant to take on a lot of people because I know what my stress level is like. I'm comfortable with 2 to 4 births. I know what it feels like to do 8 to 10 births, and it's exhausting, you know. And so I have to be real with myself as well. And so what we have done as members of the Midwives National Alliance, we have made ourselves available to assist one another, so that if I am tired, or if I feel like I'm coming down with some symptoms, I can call on somebody else. And it's real important for us to be in tune with our bodies, know what it feels like, being able to recognize when you feel your immune system dropping. For me, I feel I don't feel my optimum. I might not be feeling any other symptoms, but I'm not feeling my optimal self. And so once that starts rolling over to a little a mysterious cough that just came out of nowhere, or any other symptoms, it's very important for us to be honest with ourselves and call on your other midwives to be able to cover for you. That has not occurred yet in the Atlanta area. It's about 50 midwives that are here. There's only 5 of us that are melanin that are practicing. The rest are, Caucasian. But I have not heard of any news of anybody, getting sick. But we do have that commitment to one another, to be able to call on one another. And another really cool thing too is having platforms like this. And last week, Jenny Joseph led a platform for the elder midwives to get together on Zoom and talk about what it is that we're doing. And so having these conversations is a good thing. There might be people that are not attending tonight, but if we're going to have continual ones, like you mentioned, then those people will be able to catch up on the next one. And go on Facebook, surf around and see what other organizations are doing in terms of podcastings or webinars, because a lot of times they're coming up with something new. This virus is new, and we're learning something about it, seems like every other day. And that might mean that we have to modify things a little bit more. At first they said that it was, a virus that had droplets. And so now they're thinking that it is also airborne. So then that means where once before they said don't wear a mask, not unless you're coughing. Now it's like wear a mask anyways. And so those are some of the changes that we've had to make, and even new people who are calling. Typically, I would have them come over for a 90-minute or 2-hour consultation, and now it is done virtually as well. And even they are appreciating it as well. And I've had people to, contract my services doing it virtually, and I think that's powerful because one, these women don't want to be up in the hospital. These hospitals are jam-packed. They're turning people away until they're pretty much at death's doorstep, and they're overcrowded. They already have their car accidents and cancer patients and hypertension and diabetes folks. So it's like Corona just came and like boom. And so now when I drive around some of the local hospitals, I see white tents sitting out in the parking lots. You saw on the news the other day where they're turning Central Park in New York into a triage, where they're treating people. And so it's like these people who are low risk don't need to be in an environment like that. And so what we're hoping to do is to make an appeal to our governor to see if the governor will give us temporary or either provisional licenses so that we can drive around the streets and take care of the people who we have contracted our services without worrying about being pulled over. And if we are pulled over, then we have something that maybe an ID that we can show that we're legitimately going somewhere that's essential. And so that's what's in the makings right now, because there's certain parts of Georgia where there's curfew. Like where I am in South Fulton, we're under curfew from 9 o'clock in the evening to 7 o'clock in the morning. And we have to be able to get to our parents. And so I think I probably exceeded my 8 minutes, and I'm not going to hog it because we got some other wonderful speakers as well. And I'm happy to join in again on the Q&A. Thank you for having me, Hagi and Jamarah. This is really good. I'm proud of you all. You millennials, y'all are great. I'm gonna learn how to do the Zoom thing too.
You're doing it. Thank you, Sarahn. I appreciate you sharing your wisdom. Thank you so much. So I wanted to just allow our other three speakers to just do your introduction. And so folks that are on the call can know what we have to look forward to. And then we'll go into the next presentation. So if all three of you could introduce yourselves. Let me get my little order together. Notes. So the next person I think was Nubia. Am I right?
Yes.
Yeah. Okay, Nubia, if you could introduce yourselves, name, pronoun, location, and any organizational affiliations, and just a little, 10-second about what you're going to talk about.
Sure. Yeah. So greetings, everybody. I'm Nubia Earth Martin. I'm in Yonkers, New York. Pronouns are she, her, hers, and having a little bit of issues with my internet, so I hope I don't get cut off. So basically, I've been doing birth work since 2008. Started as a childbirth educator, then became a birth doula, postpartum doula, and then a lactation consultant. And I received my master's degree in midwifery from SUNY Downstate in Brooklyn in May of 2018. So myself and my midwifery partner, Tikarima Tisi, we've been attending home births. We both knew when we were in midwifery school that we wanted to go directly into home birth. And in addition to home birth services, I operate and founded a nonprofit organization called Birth from the Earth. We provide community childbirth education. We offer monthly chocolate milk cafe, which is free breastfeeding support specifically geared towards women of color. And we train birth doulas, postpartum doulas, and home birth and midwifery birth assistants as well. And one of the main things that Birth from the Earth does is offer scholarships and assistance for those who are interested in home birth but possibly cannot afford it, because we never want the reason that somebody does not come to home birth to be financial. So we try to make it accessible to those who need it the most. And we've just been receiving an influx of people who are desperately now wanting to turn to home birth. And it's been challenging because we've been doing virtual consults and trying to meet everybody on their terms, but not wanting them to turn one fear or turn away from one fear for another. Because for home birth, of course, it's a state of mind. It's a type of preparation that you do both mentally, physically, spiritually, emotionally. So, trying to talk to everybody, understand their fears, and of course, make sure that they are low risk and a good candidate for home birth. So it's been challenging, but it's also been beautiful to see people turn to their innate selves and trust their bodies. So I feel like that is kind of the bright side to this pandemic, if we can look at a bright side of it. And I'm excited to be on the call and happy to listen and hear what everybody has to say. And I'm also part of the New York Home Birth Midwives Collective. There are about 26 of us. So we have been, you know, offering to back each other up so that we're not overextending ourselves. And as Mama Sarahn said, if we're feeling like we're getting sick, we can have somebody else step in and still provide care for the people who we've agreed to be there for. So thank you.
Thank you, Nubia. Okay, Rachel, could you introduce yourself, please? And then we'll after the intros, we'll circle back around to you, Nubia.
Okay, so I'm Raichal Reed. I'm coming from the Central Texas area, mostly Austin, Texas. I do home births and birth center births, and then some hospital births as a doula. I'm the volunteer director of a nonprofit, Giving Austin Labor Support, which are volunteer labor companions that serve the Central Texas area. So from Killeen area, which is Fort Hood, almost all the way to San Antonio. And then the topic that I'm kind of discussing today and then like wanting to hear input from everybody else is mostly primarily around water birth.
Thank you, Rachel. Lodz, can you please introduce yourself?
Sure. So hi, you guys. My name is Lodz Joseph. I am a certified nurse midwife in Albany, Georgia, at a federally qualified health center. So primarily, my scope is within the hospital. And so I hope that I can talk to you more about the precautions I've been taking in the clinic, in the hospital, and kind of the funding and strategies that we are seeing as we introduce and roll out telemedicine and what that means for the prenatal and postpartum schedule.
Thank you so much.
No problem.
There's some great questions coming in on the chat, so definitely keep those coming and we'll have some opportunity to share. I definitely want to ask our presenters to keep your presentations to 5 to 7 minutes so we do have some opportunity for a discussion. And just a gentle reminder that this is a space for Black midwives and birth workers. So I just wanted to clarify that if anyone needs to excuse themselves. Also, just some thinking about like our differing experiences and protocols, you know, and trying to develop best practices out of what everyone is doing on the ground, and what works in one community may not work in another and vice versa, but we're all here to do some cross-learning and sharing. And so just a reminder to stay open to the ideas that may apply where you live and practice. You may be in a state that licenses midwives versus being in a state that doesn't. You may work in a hospital versus a prenatal clinic or versus home birth. And so we try to have a variety of providers here so that we can all, you know, learn from what the different practice settings are. And at NBMA, we're definitely interested in uplifting every type of Black midwife, no matter what your certification, no matter where you enter. All of our work matters to our communities. So I just wanted to uplift that. And that being said, I'm going to turn it over to Nubia.
Yeah, so I think what I wanted to talk about the most for me, what's really at the center of what I'm dealing with now is how to normalize care for the clients that we have in the midst of all the changes. And I think Mama Sarahn was speaking to the fact that, you know, there are social distancing parameters that we have to put into place, but then how do we still keep that connection with our clients? And one of the things that I'm grateful for is that before all of this, during our prenatal visits that we would do with our clients, we're teaching them how to palpate their bellies. We're allowing their, you know, partners, sisters, mothers to listen with a pin-or-ed stethoscope, you know, so they know how to kind of find the heartbeat. So these are things that are familiar to them. It's not a new skill that they have to kind of apply now. We allow them to feel for their own, pubic bone and, help to measure so that they know what they're feeling for and they can be a part of their care. So I feel that that part is not a big jump. I'm the perpetual analog girl in the digital world, so doing all of the Zoom is a big adaptation for me, but I feel like my clients have been very resilient in the fact that we've already established a connection and we make sure that they have a blood pressure cuff, that they have a working thermometer and scale. We're checking in obviously about, any symptoms that they may have, pregnancy related or otherwise. And then for the key visits, like where we may need to draw blood or we're doing our glucose testing or GBS testing, of course, we're doing those in person, but wearing, our protective gear, making sure that we're symptom free if we're going out, making sure that our clients are symptom free. And the big problem right now is that we do not have a lot of masks. So, trying to, amongst the small community of home birth midwives here, share supplies as we can. But for me, it's been about trying to normalize everything for them because we know how stress impacts the pregnancy regardless of a pandemic. And especially for the people who we're serving, a lot of them had past really traumatic birth experiences, and that's what brought them to home birth. So trying to make sure that we keep that stress level down and that we allow them to express their fears and express their concerns. So that's the other reason why, we're getting a lot of inquiries and we're not turning anybody away in terms of consulting with them. Not to say that we can take on everybody, but we are at least hearing them out, and then pointing them in a direction to what might be appropriate for them if home birth is not, safe for them. So here in New York, the Brooklyn Birthing Center, which normally would only take people up to 36 weeks for a transfer, they are now taking people up to 39 weeks. They are still allowing doula, partner, they're still allowing 3 birth support people to come as long as they're symptom free. They do have enough protective gear for them. So that's really important because for anybody who is planning on birthing in a hospital, right now it's only one support person. So if they were planning on having their partner, but also having a doula, they have to make that decision. So yeah, for me, it's all about normalizing right now. And I invite suggestions for other people who are in private practice and how they are being able to keep that connection with their clients. And, also happy to provide any ways that we've been able to help our clients and still being an integral part of their care and not feeling isolated during this time, but allowing this time for internal reflection and really preparing for the home birth process.
Thank you,
So,
Nubia.
Yeah. If anybody had specific questions for me about that.
Yeah, if you do have specific questions for Nubia, please drop them in the chat. Nubia, you can take a look at some of the questions if you go to your chat box.
Sure.
If there's any that are directed toward you. And then after all the presentations, we'll get into Q&A. I love what you shared specifically around client autonomy and involving the partners. I think for me as a midwife, that's been interesting, trying to figure out telehealth and how to maintain that connection. But I think after a while, it kind of starts to feel like a sister girl conversation. And so I appreciate the FaceTime and the telehealth exchange and how clients really appreciate that we're taking those precautions and still keeping them engaged and even educating them more about their bodies and their own kind of sense of independence and autonomy to take care of themselves. So thank you for sharing that. I'm going to turn it over to Raichal, talk about water birth. Thank you.
Okay. I also forgot to mention that I'm a student midwife, but basically for water birth, I've done a lot of research with WHO and the CDC on just their updating paperwork and PDFs and videos. So like currently, as of March 15th, there's no contraindication to water birth. There have been cases of finding the virus within the fecal matter of the mother, especially when she's pushing. But as of this point, it's mostly, for the most part, diluted. And so there's no like real risk of transmission between mother to baby in that way, as long as we're using proper PPE. And I don't know about you all, but I have like a little fishnet that I just kind of like scoop and get rid of it, that there's no real risk to us there. So here in Austin, there's a bit of a 50-50 split between water births and not. All the midwives here have kind of come to the consensus of just giving birth pools and helping mothers afford birth pools that can't. That way we can kind of control, have a liner, do things in that way for families who can't. We've completely kind of isolated one restroom for the mothers. So like family, the kids, if they're still in the home, aren't allowed to go into that restroom. So it kind of stays completely isolated to the mother, even from us. That way it just kind of further protects her in that way. There hasn't really been any evidence on showers, but there is no current data that supports that it's coming through the municipal like water systems. So people who run off wells, we haven't really been in contact with, and I guess not enough people are using well water for them to make data on currently, but it's not coming through the drinkable water faucet, hoses, showers, places like that. So as of this moment, there's no current data that supports that water birth isn't healthy for moms. And I personally find comfort in it just because I've seen so many mothers just completely relax and find, you know, their breath and come back to peace when they're in water. And a lot of them have been worried that they're not going to be able to be in the shower and sit in the birth pool while they labor. So we kind of treat it as if every mother has GBS. So we just completely scrub the tubs, scrub the showers, use the treatments that we normally would for a mother who's GBS positive that's still delivering at home or at the birth center, and then work from there, still continue to monitor her blood pressure and her temperature and everything like that. We haven't had any confirmed cases in our home birth center circuit. Most of them have still been in the hospitals, but that's kind of my spiel on that.
Thank you for sharing. And in the interest of time, I'm going to keep it moving. Lodz, are you ready? I'm going to turn it over to Lodz Joseph to talk about her experience in the hospitals, vertical transmission, and some fresh ideas for all of us.
Hi, you guys. My name's Lodz Joseph. I'm one of the midwives in Albany, Georgia. So I work at a federally qualified health center. I'm just looking at my little list of notes. My pronouns are she and her. And so some of the big questions I know people have been asking are, what's the relationship to limiting visitors? That's been like a big thing I've been asked on Instagram, Facebook. It's up to the hospital. So because I work at a fairly qualified health center, we don't dictate the hospital policy. And so for the hospital like culture. So and that's like the truth of where I am. So what I would say is, at this point, hospital visitors, the last few births that I've attended, you know, there were 2 visitors, then the last ones, there was 1 visitor, and in the hospital now, what they're doing is they're making sure everyone gets their temperature, mask, etc. And then right now it's 1 visitor. So that's where we are right now. In terms of PPE, because I'm in a clinic setting and hospital setting, PPE is really big. And I forgot to mention, I'm also going through the centering program. So we do group prenatal care. So my site changes. So in the clinic, I have gloves, mask, protective mask. Like when I'm doing a procedure, we have enough gear right now, so they're urging us to use it. On patients who have a temperature, cough, shortness of breath are not allowed in the clinic. And so what that means is, especially for patients who don't have telephone numbers or who don't have reliable modes of communication, when they come, I have to check to make sure that there's a way we could actually get in touch with them. So that's, you know, kind of a thing that I've noticed. If we're turning patients away, there definitely has to be a way to get in touch with those patients. And there's a way to bill. I immediately call the patient. I'm like, can I do a virtual visit with you, telephone encounter, or do you want to reschedule? So I have to offer the patient that choice. So that is one thing. In terms of the centering program, at this point right now, we're still doing it because it's such small amounts of people. And so we just are 6 feet apart, and then individual prenatal care still happens. The group prenatal sessions are only once a week. And so right now, I think the health department census is so low that it's like just a few people, and we have them kind of literally 6 feet apart, and we go from there. Right now, as of this time, I find a bit of like solace in looking at the Phoebe ticker. So every day around 12 or 1 p.m., Phoebe shares their stats. As of right now, we have no pregnant people who have tested positive. As of this moment, we have no people that have delivered and are testing positive for postpartum. And that's kind of important because I've noticed some other cities, talking to some friends and just some other midwives, that delineation may be being made, may not be being made. So I do try to like look for those numbers. So as of right now, it's community transmission in Albany, Georgia. We're a huge hub for COVID cases because there was just a New York Times article about it. Unfortunately, someone came to a big funeral, and the funeral had like over 200 people who attended, and that funeral home and that funeral kind of helped, you know, the coronavirus spread. So around here, you know, you're hearing the cliche comorbidities. The other thing that is very, that's been a thing in Albany, Georgia, and it's in a lot of our patients, our BMIs, that we have patients with BMIs over 50, and everyone who has tested positive, or at the time when the hospital was giving us detailed reports, the deaths initially, everyone had a BMI over 50. So you have comorbidities, but also, you know, those really high BMIs, we're also seeing that kind of profile. And why that worries me is because many of my patients that we see have BMIs, quite honestly, sometimes 60, 70, 80%. And so those patients, you know, I don't think that there are home birth midwives that see patients with BMIs of 70 and 80%. So we take care of those people. So that's one thing I'd say. The other thing too is that in my prenatal visit, I kind of have a spiel. I know all of you were talking about the precautions you take. The precaution I take is to re-ask. Sorry. 3 dogs in our house. Might be a cat outside or something. But okay. I make sure to ask the triage questions, and it's not that I don't trust my team. I just know that other people aren't responsible for my safety. And so I have had patients who have fevers, who have come in with infants with fevers, who have been exposed to people with the COVID positive. So somewhere there's a breakdown in the triage person outside, the front desk person, the person who triages them to seeing me. So you have about 3 or 4 people. And so I immediately step out of the room. The patient should be either seen in an isolation room, or they need like protective, equipment, including the mask. So I think those are the efforts we're seeing. And I would just say, make sure you're protecting yourself, especially if your team is kind of slipping, because they may not do their due diligence to ask those questions. So that's one thing I would say. And the other thing is I just incorporate it into my prenatal, just like the warnings, vaginal bleeding, leaking fluid, contractions, fetal movement, fetal kick counts, right? We're talking about fever, shortness of breath, dry cough, GI issues. Phoebe has a number, the area I am. So I talked to them about the precaution of like calling 312-1919, the directions for where how you go up to the emergency room, because there are specific instructions we're letting the community know. So that has become part of my prenatal care as well. And then if I'm in the hospital, that one person in the room, I'm talking to them about it. And then on postpartum, it's a reason to come back to the hospital for sure. So yeah, looking forward to your questions. I hope that I did not go over my time.
No, that was perfect. Thank you, Lodz. That was a lot of information. So it's 8:03, and we have until 8:30 for the rest of this call. And I want to make sure we have time for questions. There was such great information, and I see a lot of questions coming in specifically for Raichal and Lodz, I think, around water birth and about midwives in Albany. So we'll jump into that. And then just as a reference point, so our speaker is Mama Sarahn, who is a community midwife in Georgia. I'm a licensed midwife in Florida. Lodz is a CNM working in the hospital in Georgia. And Raichal is a student midwife from Texas. And Nubia is a CM, I got that right? CM from New York. So there may be different questions that you have related to whatever your point of entry is, whether you're a student, an assistant. I see some questions on here around assisting and PPE. So feel free to direct your question in the chat box to the speaker that you think can speak to that. And so I'm just gonna start with looking at the questions in the chat. So it says, for any of the midwives, for those states that are limiting or preventing labor support, how can we support birthing people that must give birth in a hospital, birthing people deemed higher risk? That question was from Leon. Hey, Leon. Anybody want to take that one?
Sure. I think if we want to support people, we need more doulas, especially in this area. We have right now, there's like a small Facebook group, primarily a few white women, and then there are like maybe 2 Black doulas. They went through all the education, but they're like, nobody wants to hire me, so I can't get hired, so I can't work. So that's what I've heard. So there was one Black midwife for sure. We have her like stuff in our prenatal packet. and I talk about it, but I think people think a doula is like an Atlanta thing and not a thing down here. Or they don't realize they have doulas, like their family members, but truly just labor support, some of them are missing that. So I would say, maybe reaching out to some of the smaller areas, if you're in like an urban rural area or a place where the hospital is the big business place, or reaching out to maybe Department of Public Health and seeing if, Black mamas, Black birthing people are interested in those services.
Thank you.
Yeah, I just wanted to add that here in New York, we have the opposite problem. We have an influx of doulas. The problem is if the hospital is only allowing one support person, that they have to make a decision between their spouse, partner, or the doula. So I've been seeing a lot of doulas do virtual support, or are doing the majority of supporting them at their home, and then like when they're in very active labor, they're going to the hospital and they're continuing out their support virtually. So I haven't had a chance to ask any of the doulas how the virtual support has worked. Has it been successful? What are the challenges? But I know that's what's being done here. And somebody else asked a question in the chat about how can student midwives help at this time? I think for sure with a lot of people going towards home birth, we definitely need more birth assistants. So from last year in February to date, we at Births from the Earth trained 18 birth assistants. So they are in Yonkers, Bronx, Brooklyn, Queens, Harlem, and New Jersey, actually. And that's been really helpful because as we're being spread thin as home birth midwives, we need that second set of eyes, ears, and hands that knows CPR, knows neonatal resuscitation, especially for out of hospital settings, and can take vitals. So I think that's really important. So if you have those skills, we definitely need you. And I know I've been circulating the list of people who have trained with us to all of the home birth midwives because they absolutely need that. So that's a great way, if you have those skills and that knowledge, that you can help.
Thank you. So I see a question. This is from Carmen Mojica. Hey, Carmen. How are folks organizing around helping low-income folks afford home birth? Great question.
I'll jump in on that one too. So committed to making home birth as accessible as possible for those who need it the most. So we offer scholarships, we offer a sliding scale. So our practice offers sliding scale. Me as the founder of Births from the Earth, I offer scholarships. So we do everything that we can to make it accessible for people. I don't think we've ever turned anybody away due to funds. That's never been a reason why we have not been able to service somebody, and I'm committed to that. So I'm steady writing grants all the time because that's one of the main issues. We have a lot of home birth midwives, and I'm not faulting anybody, but who will not take people who have Medicaid because Medicaid doesn't pay a lot. And my thing is, if you can take a bunch of clients who have private insurance that's going to pay you top dollar, you can take some Medicaid clients. And not everybody feels the same way, but when I know that it's a matter of life and death, I feel that it's important that we extend ourselves in that way. And I have 5 children, so of course I have to keep a roof over our heads, I have to feed them, but I also do not want to see, I can't have it on my conscience that somebody ended up in a hospital who really wanted a home birth, was a good candidate for home birth, but because of money, they weren't able to attain it. So that's one of the things that I'm doing. I can't speak for any of the other midwives, but that's what we do in our practice and with my nonprofit.
I would like to add to it. Many of the midwives here in Atlanta are, especially the moms that are due within the next 2 to 3 months, we're offering them a discount that we feel like we can live with. and something that can be affordable to them. Some of them we are also, well, with everybody, we offer payment plans, but if they come early in their pregnancy, they can pay it off prior to their birth. But for these moms, because they're coming in late like this, then making provisions for them to pay on their account after the baby is born. And right now, our fiscal agent, I don't know if I have the liberty to name who they are right now, but they are too doing the same thing. They're writing grants so that the midwives can still get paid what it is that we are accustomed to getting paid. And so this would probably be like on a scholarship type of thing where we'll offer them. Well, they'll pay the grant will cover the balance of what it is that they would normally pay, so that like yourself, Nubia, so that we can keep a roof over our head, as well, and keep bread and butter on the table. And so I think that's a great thing, to be able to have some grants out there to make it so that it's affordable, for people. We don't turn people away because they can't afford it either. We try to work something out with them, even if it's some kind of bartering or whatnot. But yeah, that's my input.
Thank you, Mama Sarahn. So yeah, here in Florida too, this is a state that has Medicaid coverage for midwifery care, so people can have home birth or birth center birth, and it's covered by Medicaid. Of course, there are some costs that are not covered by Medicaid, and so there are a couple of nonprofits here that help to bridge that gap or cover that cost, or also for people who don't qualify for whatever reasons or are uninsured. There's Southern Birth Justice Network, which is the sponsor of National Black Midwives Alliance. We offer free, low-cost, sliding scale doula and midwifery services. And what I hear, probably a lot of folks on this call could say the same thing about their practices. And I think that as Black people, we are the most philanthropic people. We believe in access, and we do go above and beyond so our people can have what they need. And at the end of the day, we should also be advocating that our government, cover the complete costs that are associated with pregnancy, birth, and postpartum, so that people don't have to go without, and so that we can also be sustainable in how we offer that care to our communities without having to either be in a situation where we're forced to decide, are we going to pay our own bills or are we going to turn this person away? So that's just a point of advocacy that, we need to keep lifting that up, that all services need to be covered and accessible everywhere. So there were some questions too about water births and follow-up for Raichal. I think this is interesting, just looking at what are people putting in the water. So actually, if folks that are doing water births would just drop in the chat, what are, if you didn't already, what are you using in your water birth pools, if anything at all, and how your protocols have changed. But Raichal, if you want to just respond, people were asking what you all put in the water, and there was a conversation about Clorox versus Hibiclens. Do you have a perspective on that, or any of the other speakers?
So for me, we still use the Hibiclens just regardless, mostly because it is antibacterial, and if we can kind of keep everything kind of, I guess, collected, like in one area, like mom and baby together, that's a lot easier to deal with and to manipulate and make sure that, they're safe together and then are also safe from other people. Some people do use 1 bottle of peroxide. Our pools are kind of on the smaller scale, but I know if you get like the Aqua Doula or those like really big like pool type ones, I could see how you would need more. And then for the Clorox, usually we just fill the pool up, or about halfway up, pour about a cup of Clorox in it, let let it set, and then completely rinse it all out. And that kind of protects mother and baby. And that's with the liner in the pool. Most people I've seen make it work. They do make certain liners for certain pools that I've seen, but I've seen some partners and parents and things buy like shower curtain liners, like the ones you put on the inside of the tub, and figure a way to kind of fixate that, like a brand new one, obviously. So it's kind of a combination of protecting the pool, you know, itself, and then also protecting the mom on the other side of it.
Thank you. Does anyone want to add to that? I saw someone mention in the chats, I lost the name. Oh, I think it's Terry, about asking, what about essential oils? Does anyone have any perspective on that?
What was the question again? Can you repeat that?
What about using essential oils in the pool? Is anyone doing that or have a perspective on that?
President Trump changing his tune on the coronavirus. At one point, he said it's not.
Oh, please mute if you're listening, watching TV. Thank you.
You mentioned it.
Jamarah says, I would be worried about essential oils degrading the plastic. She also said that 30 cc Clorox is what's being recommended by Water Birth International, less than what is in a chlorinated pool. Just sharing some perspectives on best practices. We can move on from water birth if no one else has anything. All right.
Hey, this is Karina. I'd be concerned about the baby not knowing if there was any type of allergies or sensitivities with the baby's skin being so new, even if it's diluted.
With what? With the Clorox or with the oils or all of the above?
With the essential oils.
Okay. Yeah, a lot of people do have reactions to essential oils.
Hi, this is Maride, and I was actually going to say in regards to the essential oils in the pool, you really don't want to put anything in there because the baby, you know, essential oils anyway, the baby and the amniotic fluid in the mom, there's all this biostatic fluid. It's already sterile. So if you're putting essential oils in there, it's messing with that whole balance.
Mm-hmm.
So I kind of would have avoided that. I would use it in a diffuser. I'd put it on cotton balls, but I would keep it out of the water.
Thank you for that perspective. And there are some folks that are opposed to using anything in the pool or are not currently using anything in the pool. And, you know, like I said earlier, we're all gonna do what we feel works best in our communities with our, you know, practice guidelines. But I do think it's important to be educated about what is being recommended by public health experts. I think someone referenced the Water Birth International, and it's a good video to watch. Some of you all are aware of Barbara Harper, who's considered the, you know, water birth kind of expert worldwide and trains thousands of health workers on how to do water birth. And she put out some guidelines, I believe yesterday, just recently, in a paper on best practices for water birth. So that's a resource that I think someone dropped the link in here somewhere. If you scroll up, FA, thank you, FA. Hi, FA. There's a link in the chat if anyone wants to read more or watch the video on best practices for water birth during COVID-19. All right, so we're going to move on from that. I think there were some questions around, maybe Lodz, you can answer this. Are there home birth midwives in Albany or serving that area? I don't know if Mama Sarahn or Lodz, if you could answer that question.
Yeah, absolutely. So right now in Albany, Georgia, not that I know of.
Lodz, I'm sorry, your audio, something happened with your audio.
Hello?
Yeah, there's an echo and you sound kind of far. Maybe, I don't know if it's your internet.
Can you hear me now? There's no noise. Is it clear now?
It's a little bit more clear. You can go ahead.
Wait, let me try. Is that better?
About the same. I mean, I can understand.
Okay.
It sounds a little robotic.
At this time, there are no home birth midwives. To the point, I know that should I get pregnant, I know I've already reached out to home birth midwives. That the question is, who will come down to Albany, Georgia? That's the question and conversation. But from my experience, even trying to help some moms navigate that, who have the insurance, who have the means, and are okay with doing it, it is who will come down to Albany, Georgia, especially for a first-time mom.
Thank you. And we see that in a lot of areas that are not highly populated. There's not a lot of home birth or out of hospital birth midwives or birth centers. And so those communities don't have a lot of providers, which is why we need more of us. Okay, so another question I saw, does anyone know of Black home birth midwives in Connecticut? Shout it out or type it in the chat if you do. Oh, and I think Hagi responded, systemmidwife.com is a resource that has a directory of midwives. So that's a great place to go if you're searching for a Black midwife, and you can put in your area, your zip code, I think, and it will give you a listing in that area. Cool. All right, so other questions? How are y'all handling all of the calls that you're getting? This is from Tony. Hey, Tony, one of our amazing mentors. And Tony says, I am a bit overwhelmed with just fielding calls. Anyone want to speak to that, Nubia?
Yeah, so we've been having people contact us via email rather than phone because, yeah, I can't imagine if people are calling. And we let people know that that's because if we have current clients who are term, we need our phone lines to be clear. Like, I need to answer the phone if it's somebody updating me on where they are in labor or, you know, if there's something urgent. So rather than having people inquire with us via phone, they send us an email, and then we are answering emails as quickly as we can to set up virtual consults, and we'll do X amount per day. Consult is anywhere from 30 to 45 minutes, so we can get, you know, pertinent information, explain our practice guidelines, see if they're a good candidate, if they've had any prenatal care to date, have an opportunity to look over their records. But, you know, knowing our limits,
but how do you
for somebody in labor. So even though virtually it is tiring, it's a lot of energy to you know, answer those calls and connect with people. So setting a limit for how many people that you're going to consult with each day, I think is really good. And if you are getting a lot of calls, if you can hire an intern or somebody to answer those calls, but I would recommend people reaching out via email. That way you can respond to them in the order that they come in, and also keep your phone lines clear.
So today specifically, I had 36 text messages from different people. My phone number, of course, it was my Google number, it's on my website. So that's how people contact me. So, I mean, you go back and text 36 people your email address so they can email you. But then, of course, then that would be you having to answer all the emails, you know? So like, it's a bit overwhelming. And I mean, like, this is every day. Like, every day I get multiple calls, multiple texts. Of course, I can't do consults with everybody. And so I don't really, so most of you guys have students? Is that what you're doing? And your students are handling your calls?
So I would just share from the birth center that I work with in North Miami Beach, they recently had a webinar for potential clients. And I thought that that was a brilliant way, like just get on a Zoom or whatever platform, and you get everybody kind of in the room and give them all the same information at the same time. And many of these people are late, wanting to transfer late, 32 to 38 weeks, some even later than that. Just kind of gathering everyone together as kind of a cohort and giving them all of the same information. And then if they want to move forward from there, at least you haven't, given your individual energy to so many people, because it can be overwhelming and exhausting. And it's also, I think, in this time, really important to know your own boundaries and your own capacity. And to be able to say, I'd love to, but I'm stressed right now, is an okay thing. And to have to.
I would add to that, Jamarah, that what we actually want to turn it into is a 3-part thing. So an email that goes to every inquiry that says, here are some steps you need to take before we can connect with you. And so fill out this online form, watch this webinar, and if you are still interested at that point, click this link to set up a time for a consultation. Just because of the amount of labor it's taking to field the calls, even the energy of the person on the phone with all of these like super panicked, anxious husbands are calling, mother-in-laws, grandmas are calling, just the energy of the person who's even talking to these people when they call is a lot. So we did the webinar, it's recorded, we send the recorded link to people. And if they watch that and they still want to talk, the webinar was 2 hours. If they watch that and they still want to talk, then ideally they are scheduling their first visit. And they're not coming in for a consultation because the webinar answered all their questions and they're pretty sure that's what they want to do. But my goal by next week is to have an email response that sends them through like a Google form or a type jot form that asks them a bunch of questions, including the screening tool that we're required to use by the state to okay home birth and birth center clients, and then sends them to the webinar and then asks them if they've done both of those tasks and they still want to come in for a visit, or they need to talk on the phone to schedule a consultation in a calendar that has set times that people are available to have those conversations.
That's beautiful. That's beautiful.
It's just arduous. It's arduous.
I have a suggestion for Tony.
Oh, sorry. Go ahead, Nubia.
Sorry, I just had a quick suggestion. I was just thinking, since they're coming through your phone via text, that maybe you can set up an auto response in your text messages, that if you're inquiring about, birth services or whatever it is that, the services that you offer, then your email address could go to them and they could get back to you that way, so that you're not having to text each individual person your contact information for email. So maybe that could be, that might be helpful.
Okay, I appreciate that. Yeah, the webinar sounds like a great idea. I think I'm gonna do that this week. The problem for me, of course, is I'm a solo practitioner, and typically I do 6 to 8 births a month. I don't do like this mass 20 births a month or whatever. But I'm also the only Black midwife in the state. So when Black women are scared or fearful of their providers, they always reach out to me. And so, because I'm like the one who's visible, the only Black one. So that's hard too, but I think the webinar is a really good idea, because that will answer questions. I'm like, thank you for that nugget. So I can move forward. Yeah, because I'm like, I got to my office this morning at 7:30 and I'm like leaving my office now. And I'm leaving everything. Like, I'm like, I can't send no more ultrasound reports today. I'm not doing nothing today. I'm just like going home and I've got to go milk a goat and then I'm going to bed. I mean, that's it. Because I'm also on call. And I think So with the auto, I'll have to Google about the auto response to the text messages, because that also does sound like a good idea. But when I've looked at that before, it seems like it will send it out to everybody. And then, I mean, people I'm gonna call for, I don't want them to get that message. I don't know, I'm gonna look at that. I appreciate you guys for that, for sure. Thank you.
Tony, you have some, if you look in the chat, you have some folks offering to help virtually offer support. I think there was even a local person. So I think it's really beautiful. I'm like watching the chat and there's like all of this cross-sharing of information happening, which to me says that folks really are both needing support and wanting to stay connected. And so since it's 8:30 and I'm so sad that we have to wrap up, there were at one point, I think 82 people on this call. And it's just beautiful to see all of the sharing. I saw one person, I think Asasia, asked if we could make a separate Facebook group for Black midwives to stay abreast of current data and evidence during COVID-19. And I just wanted to see how folks felt about that. So you can drop a thumbs up or a yes in the chat if you would like to see that happen. And then we can create that space. I would be happy to do that. We have all of your email addresses because you registered for this webinar. There's great idea sharing about how on this chat about how doulas can get involved and student midwives and people offering their support and trying to stay connected. And I think that's what we're gonna need to do. I think as Black folks in particular, one of our main strategies for how to survive any crisis is resilience. I was thinking the other day about all of this literature that's come out around PPE, and we didn't get to really talk too much about PPE. I saw there were some questions, but about wearing head coverings. And I was like, oh, we got that. Like Black women, we got that because we do that already, like, right? Head wraps are just like a natural protective covering that many of us already utilize. And so just thinking about the ways that our community is already ahead of the game, already resilient, and on the front lines is the reason that we wanted to do this webinar. Wow, I see a lot of yeses. That is awesome. So we'll follow up and just if everyone could briefly just come on camera, come off mute. It's our tradition as NBMA to close as a circle, to give appreciations, even if it sounds like a chorus, just say your thank yous and your appreciations as we say goodnight.
All right, I'm gonna call you right back, Keisha.
Give thanks.
Thank you. Bye-bye, everybody.
Hey.
Thank you.
Good night.
Thank you, Haji. Thank you, Jamarah, Mama.
Hey,
Thank you.
Thank
Hey, everybody.
Thank
you. Thank you.
My honor, I see you.
I see you. For yourself.
See
you in a minute.
Night, everyone.
Check your email.
Hey, tomorrow.
Night, everyone.
Good night.
Good night.
Good night.
Good night.
Thank you. Good night. Good night.
Good night.
Yeah, see
You don't want to
everybody.
say good night. You
Night.
don't want to say good night.
Stay safe.
Don't go. Don't go.
Night.